ladies and gentlemen, welcome back. This is an extra panel during this COVID-19 pandemic. I'm very glad to have Dr. Joao, Flavio Nogueira from Brazil, from Fortaleza. Good afternoon, Joao.
Good afternoon.
So we decided very quickly to add this panel because of it's very important for us to have educational training and not only to single cases, but also educational and teaching material for providing the exact field of each of the ENT panorama. And regarding to that, we decided to have also some anatomical dissection. And today, Joao is going to provide us some indication regarding the middle ear anatomy and how to reach with the endoscopic approach inside of the middle ear. So I will remind to all the attendees to to have their question at the end of his talk, and I will lead the torch to Joao for his presentation. So please go ahead.
So thank you very much for this invitation. For me, it's very nice to talk to you, and I'll start to share my screen. I didn't prepare any formal presentation because I think for a dissection, it's better to have videos or to have movies. So I will show some videos of dissections that I've done in several congresses throughout the world for us to understand the middle ear endoscopic anatomy, which is the same of the microscopic or the macroscopic anatomy, but since you view with a different kind of view, it's a little bit different. So first of all, I would like to show this movie, this dissection I'll put on full screen. And then we'll see, this is a right ear. So let me just put a little bit here. Yes, this is the tympanic membrane, the right tympanic membrane. This is superior, this is inferior, this is anterior, and this is posterior. As you can see, you can see the malleus here, the malleus cap, which is here is kind of a cartilage here, and it has a good cleavage. And this is the external auditory canal. So this is not a surgical demonstration. If it was a surgical demonstration, I would show how to infiltrate, how to put the cottonoids. This is rather an anatomical dissection, anatomical demonstration. So the first part of the demonstration, of course, is to elevate the tympanomeatal flap. This can be done with several instruments. Of course, in a cadaver, it won't bleed, as in real life, so you don't have to worry about the bleeding. And one of the first questions that people usually ask when we are doing this dissection, and this dissection can also be translated into the surgeries, is what size should be my incision here for the tympanomeatal flap. So in the dissection, we always take the malleus as 12 hours, as noon, here, and then we go a little bit anterior to malleus, like 1 o'clock, and then we do the first incision, and then we come back and complete the incision all the way until 6 o'clock. So this incision, of course, in a cadaver will not bleed. And what should be the size of the tympanomeatal? As you can see, I was using, first of all, a knife, and then a rosin, and then you can measure with the rosin, like 2 rosins, and then you can have the tympanomeatal flap. So once again, we can do this marking of the incision with a knife. Of course, this should be not done in real life, because as you traumatize the external ear canal in a normal patient, it's going to bleed, and bleeding is a problem for us. So we use the rosin or the round knife, of course, to do the cuts. It's very important in dissection and in surgery to have a very good cutting instrument, because if you have a very sharp instrument, you won't need to pass the cut several times, and then you have a more clean cut and less bleeding, of course. And then you go, just like traditional microscopic surgery, all the way to the bone, and then you elevate this tympanomeatal flap. Since this is a section, as you can see, I'm not very delicate, because I want it to be fast. the dissection. So this is the first, and rather this is one of the most important parts of the dissection, because actually this is probably the whole dissection is elevating the tympanomeatal flap, because the other parts of dissections are more contemplating or contempling the anatomy of the middle ear and removing some and some stuff like that. So you go all the way here to the annulus, and with the endoscope, with this close view, it's very good because you can really see some important structures just as the annulus. Sometimes using other instruments, you cannot see very well, or you think you see, but you don't. So we go here, as you can see, there's no bleeding, it's a cadaver, and you see here the region of the annulus and the region of the annulus canal. And as you can see, we go all the way here to the malleus also. Then after we reach the annulus, the region of the annulus, we can elevate the annulus to enter the middle ear space, which is the space that we are going to work, and the space that we think is very important for us to understand the anatomy, because most of the inflammatory conditions in the middle ear, and then we talk about simple chronic otitis media or suppurative otitis media, or even retraction pocket cholesteatoma, most of those conditions, they have the birthplace in the middle ear. They happen to be in the mastoid sometimes, but most of them, the birthplace is also the middle ear. So this is a very important step in the dissection. I always use this kind of instrument, which is kind of an alligator, to try to peel completely the tympanomeatal flap from the malleus. As we can see the posterior malleolar ligament here being pulled off. We can see the chorda, and the posterior malleolar ligament with the chorda makes kind of an X. And then we can see the entrance of the Prusac space here, and then we can use the malleus cap to try to elevate the tympanomeatal flap from the malleus without tearing the tympanic membrane. This can be done in a cadaver. Actually, is more difficult than in real life. In real life, this is not very difficult. It can be done, and then you can elevate this tympanomeatal flap completely from the malleus, or leaving it attached to the ambus in order to have a very view of the middle ear to inspect the anatomy. So we are elevating. Of course, I'm not very delicate here. As you can see, we are mobilizing a little bit, or a lot, the ossicular chain. And then we can already see the malleus, the chorda tympani, the region of the Prusac space up here. We could see the posterior ligament, which we removed. We can see this anterior part of the annulus. As you remember, this is the pars flaccida. There's no annulus in the superior part, but right here, you have already the annulus back. And then you can elevate this tympanic membrane with the annulus all the way to inspect this most anterior part, which is the supratubal recess. We are going to see during the dissection. And then you can elevate the tympanomeatal flap or the tympanic membrane from the malleus. So we can already see here one structure, very important, which is the canal of the tensor tympani muscle. This tensor tympani muscle is very, very important, because this can have very good implications in the middle ear anatomy. The first thing that I try to look while doing the dissection, of course, and removing the tympanic membrane from the ambus, is the oval window niche, because the oval window niche, most of the times, if you don't have malformations, is going to be there. Sometimes if you have cholesteatoma, the malleus cannot be there. Sometimes the incus cannot be there, or the stapes, which can be eroded. But the round window niche is always going to be there. As you can see here, we can see very clearly in very close-up view the ambus, which is the region, and then we can cut here to detach completely the tympanic membrane from the ambus. So we elevated completely the tympanomeatal flap, and this is done in real life without tearing the tympanomeatal flap that you can put back again. Of course, you have to be careful about this skin here. At the ambus, at the region of the ambus, you don't have really skin. You have just 2 layers of tympanic membrane. So most of the times, if the skin is very close to the ambus, you don't need to take care. If you leave a lot of skin there, you can leave some skin for the cholesteatoma sepultation in the future. So we look for the round window niche here, and then we can already see the anterior pillar, the posterior pillar, and the tegmen. This is a very good way to understand the anatomy. We can see the incudo-stapedial joint. We can see the malleus, the cochleariform process here, the tensor tympani tendon here, which is very important also to make signals to the geniculate gangle, also to make to the great petroso-superficial nerve, to make signal to the eustachian tube to open. This is the anterior malleolar ligament here. As you can see, it's a little bit higher and more thick than the posterior malleolar ligament. This is the chorda tympani here, and this is the canal of the tensor tympani muscle. This is the region of the protympanum. This is the region of the mesotympanum. Below that is the hypotympanum. Posterior is the heterotympanum, and anterior is the epitympanum. So we are here at the most antero-superior region, which is the supratubal recess. The eustachian tube is going to be in this position here, muscle, the canal of the tensor tympani muscle, and then this is the supratubal recess. One of the most important regions for us in the middle ear is the tympanic isthmus. The tympanic isthmus is very important because it's one of the main ventilation routes between the eustachian tube and the mastoid. So the mastoid produces gas, basically nitrogen. So it has the same embryological origin as the lungs, but the mucosa of the mastoid has a lot of respiratory function. So this gas travels from the mastoid to the middle ear, and from the middle ear to the mastoid through the eustachian tube. The eustachian tube, the gas that enters is not nitrogen, of course, it's air, but this gas equalizes the system. Of course, the mastoid, the bigger the mastoid is, more gas it produces. But the mastoid, even a big mastoid, does not produce enough gas to fill up completely the system. There's always a negative pressure. And why do we have to have this negative pressure? In order for the tympanic membrane to be always straightened, to be always very tightened, to conduct the sound in the best way possible. So when this pressure is too low, there will be pressure here at the malleus. The malleus will signal here at the tensor tympani tendon. The tensor tympani will signal the geniculate gangle, which is right above it, and the geniculate gangle will signal the great petroso-superficial nerve that goes all the way to the median nerve and then stimulates the pterygoid muscles, and then we do like this, and then when we open our mouth, the eustachian tube opens, and then it equalizes the system. So this has to work very well. Of course, if you have a small mouth, the greater will be the negative pressure because it's not going to produce enough gas, and then you rely more on the eustachian tube. But sometimes you have problems on the eustachian tube, cleft palate patients, or even you can have problems of reflux, adenoid hypertrophy, chronic rhinitis with turbinate hypertrophy, and then you can have problems on the eustachian tube, and then you can have retractions of the tympanic membrane, or you can have perforations. What is a perforation of the tympanic membrane? Sometimes the perforation, the finger of God, is a way that nature finds to equalize the system, because if you have a perforation, you have the same pressure of the external auditory canal in the middle ear. But what's the problem with the perforation? Here from the external auditory canal can go into the perforation and then can colonize this area here. The area more close to the protympanum is more rich on immunological tissue. Why? Because it's closer to the eustachian tube, and through the eustachian tube, when it opens, bacteria from the nasal cavity, which is full, can go up, can climb the eustachian tube, and then can colonize here. So at the eustachian tube, especially at the cartilaginous part of the eustachian tube, you have lymphatic tissues which are specific to the eustachian tube. They are called TALTs, T-A-L-Ts, tube-associated lymphatic tissue. As we progress from this mucosa to the mucosa of the mastoid, there will be more respiratory function of the mucosa and less immunological function. So that's why it's easier to find bacteria or biofilms in the mastoid region, which has less immunological compounds, than in the protympanum area that has more immunological compounds. Okay, so we can see the tympanic isthmus. The tympanic isthmus in this specimen is completely open. Probably he or she did not have problems. And then we can see the protympanum. The protympanic area is very, very important because you have some important structures here. And one of the most important structures is the eustachian tube. And the second most important structure here at the protympanic area is the internal carotid artery. So the internal carotid artery makes close relation with the cochlea, with the promontory of the cochlea, and with the eustachian tube. So it's very important to understand this. And sometimes in this region, the internal carotid artery can be dehiscent. And if the carotid artery is dehiscent, you have to take care of. Otherwise, you can have problems. So we can see here the protympanic area, the internal carotid artery here, and then you can see here the tympanic, the tensor tympanal muscle canal, and the supratubal, which is above the tube, supratubal recess. So this is a new structure, or a new name structure, that was found by Dr. Nilmal Patel, Dr. Nicholas Juflas from Australia, and they call this the proteiniculus. The proteiniculus is a very important landmark. It's like the first bone crest of the protympanic area that can be can direct you towards the carotid artery. So the proteiniculus is this first bone crest, and as you can see, it's like the crista ethmoidalis that can lead you to the sphenopalatine artery. So this is the proteiniculus that leads you to the internal carotid artery. So it's very nice. And also this is a division from the protympanic area to the hypotympanic area, which is going to be down here. At the hypotympanum, you can see some cells, some recesses, but you don't have a lot of important structures, just like the jugular bone. So this is the supratubal.
Sorry, Joao, just to make sure everybody is understanding, are you using an angle scope?
Yes, of course. It's a good question. I didn't talk about this. This is a dissection, and of course, in the dissection, we can go deeper, care about bleeding. I was using in this dissection a 3 millimeter, 14 centimeter endoscope, 30 degree. So it's an angle endoscope, which is a little bit more difficult than the 0 degree endoscope.
Thank you for interrupting you, but it's very important that the participants and everybody should understand that what are you using is for anatomical teaching, and the people should understand that not always are you able to see such structure if you're not using angle scope. I'm sorry for interrupting you. Just please go ahead.
Yes, you're completely right, and thank you for. And if you have other questions, you can interrupt, don't worry. So this is the protympanic, the supratubal recess, and at the supratubal recess, you can see some embryological tissues. You remember on embryology, we have the saccus, 4 saccus that creates the middle ear and the mouth. Saccus anticus, saccus posticus, saccus superior, and saccus inferior. Sometimes you can have some embryological remains of these saccus. And when the saccus touch together, they can have a remain, and then they can have like a web or a closed tissue. This is one of the cases here at this area between the supratubal recess and the anterior tympanic space. Sometimes this is the saccus anticus and the saccus posticus, and then you can have alignment, embryological alignment, and then you can have a web that we call the tensor fold. So what is a tensor fold? The tensor fold is an embryological remainment from the saccus anticus to the saccus posticus, closes this anterior ventilation route between the eustachian tube and the anterior tympanic space. In most of us, in most of humans, probably 80% of humans, this tensor fold is present. So if the tensor fold is present, you don't have this ventilation route, but this is not going to be a problem as long as you have the tympanic isthmus opened. So this is the tensor fold, and as the power of one of the saccus is greater, you can have a kind of vertical tensor fold or a more horizontal tensor fold. So we can see here the tensor fold closing this region between the supratubal recess and the anterior tympanic space. The tensor fold is a membrane that can go all the way from the cochleariform process to the cog or to the supratubal recess. And this is a very good close-up view because we can see here in a very close-up view the region of the stapes. And this is very nice. Of course, I'm using a 3 millimeter with a 4 millimeter, the same sinus nasal scope. Sometimes it's not possible, but we can see here the anterior crus, the posterior crus. We can see here the oval window niche with this annulus of the membrane of the oval window. We can see here the pyramidal eminence and the stapedius tendon. Right above this, we can see the tympanic segment of facial nerve. So this is very important to me, and it's the second thing I always try to look for during the surgeries. The first thing is the oval window, the round window, because it's very reliable landmark. And the second thing is the facial nerve. And once we find the facial nerve, the surgery, it's very, very much more secure to perform. You have to remember, when you go from posterior to anterior, or from a retroauricular incision, mastoidectomy, to the middle ear, you don't see the facial nerve. So you on the anatomy of the facial nerve, or you rely on your knowledge of the anatomy of the facial nerve or facial nerve monitoring, which is not very reliable sometimes. During the endoscopic procedure, since we start the procedure always through the middle ear, which is the place that the disease actually starts, the second thing we look for is the facial nerve. So finding the facial nerve, even if you need to do a combined approach, gives us a very secure way to do the mastoidectomy, because we already know where is the facial nerve, the position of the facial nerve. So also we scan here the cochlear reform process, the malleus, incus, stapes, anterior crus, posterior crus, and right below we can see the Jacobson nerve. So Jacobson nerve, it's very interesting and very nice to see in a cadaver or in a real life. And in this case here, we can already see a little bit of the Dura Mater of the middle fossa. Sometimes it's dehiscent, and we can see. And as you progress towards from the tegumen to the eustachian tube, the Dura Mater descends in this position. So this region of the supratubal recess is very close to the Dura Mater. If you put a peak here, you enter the middle cranial fossa. Here also you can see the dura, and sometimes you can have encephaloceles or CSF leaks in this region, and then you can correct using the correct instruments, microscopic and correct. So this is the tympanic isthmus. So here in this image, it's very clear because you can see the three main ventilation routes. One ventilation route goes in this position, and most of the times is closed. The second one, which is the most important ventilation route, goes between the cochlear reform process and the incudostapedial joint, and then we call it the tympanic isthmus. And the third ventilation route, which is also important, which is we call the posterior isthmus, that goes from the incudostapedial joint to the facial recess region. So we have tympanic isthmus, posterior ventilation route. The anterior isthmus, sometimes or most of the times, 80% of the times, is closed. So what it means? When it's open, 20% of humans, when it's open, the prusac gets the air from this anterior ventilation route. Okay, good. But when it's closed, the prusac air gets the ventilation from the tympanic isthmus in a retrogradal way. So the tympanic isthmus, it's very important. And sometimes you can have like an acute otitis media during the childhood, or you can have like edema of this mucosa here because of inflammation, because of infection, whatever. And then you can have a fibrous disease, or like a web, or like a scar tissue in this tympanic isthmus. When you have that, then you have a blockage at the tympanic isthmus. If the posterior isthmus works, probably you're going to be good, maybe some retraction, whatever. But if the tympanic isthmus is also blocked, you will have two compartments. One compartment below here, which will depend on the eustachian tube, and one compartment above there, which will depend on the mastoid, because there's no communication if it's completely blocked. So you will have what we call the selective disventilation syndrome of the middle ear and mastoid system. This selective disventilation syndrome can create some problems, such as perforation, depending on the size of the blockage, or retractions, especially the article retraction and then evolving to retraction pocket cholesteatoma. So this is very important. And for me, which I also do sinus surgery, this is kind of the osteomeatal complex of the middle ear. If you think the middle ear and mastoid system as the fifth paranasal sinus, this would be the ostium or the osteomeatal complex. So if you have problems there, sometimes you need to open and ventilate and create ventilation routes between the middle ear and the mastoid. Of course, this is not going to solve 100% of the disease because some of the diseases are not related to selected dysventilation syndrome or blockages, but some others are. And it's important for us to look for the problem. And with the endoscope, the advantage that I see with endoscope is that you can look in a very close way, sometimes a little bit better than the microscope, to this region, which is very specific. And then you can see if you have a blockage or not. And if you do, open this blockage. So let's progress with the dissection. And then we can see once again the carotid artery, and then the proteiniculus, and then the canal of the tensotympanic muscle. And then we can go to the retrotympanic areas. But first, we will see here the superior part, tympanic segment of the facial nerve, and this structure here, which is very nice, which is the impression of the lateral semicircular canal. Sometimes we think the lateral semicircular canal is completely a mastoid landmark, but it's not only a mastoid landmark, because part of the lateral semicircular canal is actually touching here the middle ear, in the middle ear structures. And this is very important because it's a very good landmark also for you to understand where you are during the surgery, and it is a very good landmark also to find the facial nerve. Of course, I try to use to find the facial nerve the oval window niche, because it's going to be, if you don't have malformations, it's going to be more reliable. So cochleariform process again, and one very important structure here that I didn't talk is this. You have the cochleariform process, which is a very nice anatomical landmark for three things. First one is the ganglion, which is a little bit above and anterior to the cochleariform process. Second one, below it, is the Jacobson nerve that I had talked. But another landmark is this one here, this bone crest. This bone crest is called the cog, C-O-G. The cog is the center of gravity of the temporal bone. If you pick up a temporal bone and if you put like a pick on the cog, the temporal bone will not fall to any size because it's the center of gravity of the temporal bone. And the cog is a very important landmark because it will sometimes differentiate the spaces between the anterior tympanic space from the posterior tympanic space, or sometimes it can differentiate the supratubar recess from the anterior tympanic space. In this case here, we see the cog is differentiating the anterior tympanic space from the posterior tympanic space. The adductus antrum, this position here, this is the long process of the incus, and this is the stapes, as we can see, as you saw, the incudostapedial joint. And then see, even during surgery, we can have this very close-up view. Of course, during real life, during real surgery, you can have this close-up view, but you have to take care about not disrupting the ossicular chain or about not causing any lesions. And one of the most important lesions that you can cause is thermal injury related to heat. So you should never use the light source at 100%, because if you do this, you can transmit heat, and when you have those close-up view, you can burn the chorda, you can burn the incudostapedial joint, you can burn the tympanic membrane, and you can cause some real problems. So my tip during real life surgery is to use the 3mm endoscope, as you asked. And the second one is to reduce the light intensity at using a maximum of 40%. You don't even need 40%, with 30%, 20%, because the cavity is very small, different from the nose, which is bigger. This is very small, so you don't need to have a lot of light intensity. So here we can see the cog, again, the cochleariform process, protympanic region, and then we can go here to the anterior part again to see the tensofold, but this we already saw, the tensofold area. We can go here, the superior part, to try to understand the entrance of the Prusac and to see more of the tympanic diaphragm which are muscles and membranes and webs to support. But also we can go here to this region, which is the most important for me, I think, in the middle ear, and for us that perform cholesteatoma surgery. Because this is the retrotympanic area. And the retrotympanic area is the most prone area to have recurrence or residual disease when we talk about cholesteatoma, especially residual, because recurrence is one thing and residual disease is another thing. Residual disease is when you leave disease during the first surgery. Recurrence is when you remove completely the disease, but the disease appears again. So this is the stapes here. This is anterior, posterior, superior, and inferior. This is the round window niche, and this is the oval window niche. So this is the retrotympanic area. And what is important in the retrotympanic area? To see those recesses, because on recesses, cholesteatoma can be inside, and sometimes even doing a canal down with a good microscope, if you have a very deep recess, you just won't see. Even using those mirrors, sometimes you cannot see, and then if you don't see, you don't remove. And if you don't remove, you have residual disease. So this is the promontory, this is the posterior pillar, this is the anterior pillar of the round window, and this is the tegmen. So it's very good for cochlear implantation, and the guys who perform implantation, they know this anatomy very well. This is a very nice thing I call the tip of the iceberg. It's the projection of the styloid proeminence, the styloid process. So this is the styloid proeminence, the name, the anatomical name. So this is the pyramidoaminescence, and this is the subpyramidal space below the pyramidoaminescence. Sometimes you can have this small bone, can be a bigger bone, can be smaller, between the subpyramidal space and the promontory. This bone can be in a bridge size, can be like in a wall size, or can be absent in sometimes. But we call this region here, or when we have this bone here, the ponticulus, which is bridge. Right? So the ponticulus is very important because it's the superior limit of this region here, which is called sinus tympani. And sinus tympani, if you record on the literature, is the region that is more prone to have residual disease when we talk about cholesteatoma. So the region between the posterior pillar and the styloid proeminence, we call it subiculum. So this is ponticulum, subiculum, and between the ponticulum and the subiculum, we have this sinus tympani. So what is the sinus tympani? It's a recess at the retrotympanic area of the middle ear that is located between the ponticulus, the subiculum, ponticulus superiorly, subiculum inferiorly, promontory of the cochlea anteriorly, and facial nerve posteriorly. So this is the sinus tympani. This region here between the anterior pillar and the jugular bulb, which is going to be here, is called the funiculus, the end, the fin of the retrotympanum. So the retrotympanum starts here at the oval window niche, goes all the way down, all the way to the funiculus. So we have sinus tympani, and below it, from the subiculum to the funiculus, we have the sinus subtympanicum, which is below sinus tympani. So sinus tympani, below sinus tympani, sinus subtympanicum. And why sinus subtympanicum is important? Because you have two very important structures inside the sinus subtympanicum. One of them is this one here, which is kind of a finger pointing out the region of the round window niche, and it's also the floor of the scala tympani. So if you are doing cochlear implantation, and if you can't find the oval window niche, or if you want to be sure that you want to put your electrode in the scala tympani, you look for the fustis. This is the fustis, which is the floor of the scala tympani. So if you follow the fustis, you're going to be at the scala tympani, because the fustis is like the floor of the scala tympani. And then this space between the fustis, which is here, and the funiculus, sometimes, not in everyone, sometimes you can have a canal. This canal is called subcochlear canaliculus. And the subcochlear canaliculus, when it's present, it means that the pretus apex can receive air from the middle ear and from the station tube and from the mastoid through this canal, and then you have a pneumatized petrous apex. This is important because sometimes you can have like cholesterol granuloma or a mucocele on the petrous apex. And you can do transnasal if you have a very good sphenoid sinus, a good distance between the internal carotid artery and the clival area. But sometimes you have a small sphenoid sinus, you cannot reach through the nose, and then you would have to do a Tympanic approach, and then the patient would be deaf because you would destroy the cochlea. But then endoscopically, we can do, and we have described with your friends from Italy, the infracochlear approach, which is approach using the speculum when it's present and going from the middle ear all the way to the petrous apex, preserving the cochlea and preserving the hearing of the patients. So this is very important landmark. It's not present in all of the patients. It's going to be present in those patients who has a pneumatized petrous apex. So ponticulus, once again, subiculum and funiculus. Ponticulus from the superior space to the pro of the cochlea, subiculum from the styloid proeminence to the posterior pillar, and funiculus from the anterior pillar all the way to the jugular bone. So fustis and subcochlear canaliculum when it's present. In this specimen, it's not present. We don't have the CT scan of this head, but probably if we did the CT scan, we would see that the petrous apex would be pneumatized, would not have air inside. So we can see here. Another question is, where's the posterior sinus, or why it's called the posterior sinus? Because it's very important, and it's very important to know the history. So when you do traditional surgery, a traditional mastoidectomy, canal wall, and then when you want to inspect the sinus tympani, what you do? You do a posterior tympanotomy. The posterior tympanotomy is done in this region, probably here, more superior to that. And then when you do a posterior tympanotomy, you go there, and then you can see the sinus tympani if you angulate down. That's why sometimes you use the Dehgani-Mobaraki, for instance, you can look to see the sinus tympani. The guy who described this posterior tympanotomy was Professor House, Howard House. And Professor House was also one of the guys that developed the cochlear implantation. And then when we talk about posterior tympanotomy nowadays, people think that it was developed or was created to do cochlear implantation, but not. The posterior tympanotomy was developed to inspect sinus tympani and facial recess. But what is the problem? Is that you go from superior to try to inspect a region that is posterior. So sometimes, even doing a big posterior tympanotomy, you cannot see a very deep sinus tympani. So he described that, and then he did the sinus tympani. What was below was the sinus subtympanicum. But since he was coming from the mastoid to the middle ear, this region here was posterior to the sinus tympani. Can you understand that? So we call this region here between the posterior crus of the stapes and between the ponticulus, the sinus posterior, or the posterior sinus, because you have sinus tympani, sinus subtympanicum, and posterior sinus. But this region here, anatomically speaking, is not posterior, it's anterior. That's now we call this anterior sinus. So anterior sinus, this region here, sinus tympani, sinus subtympanicum. But in books, you can already find, or you can still find, this region be called posterior sinus. Understand? So this is the retrotympanic area, which is very, very nice. Once again, you have this whole 360 degree. And another important thing is there's still some bone here. The tympanic segment of the facial nerve is here. The geniculate ganglia is here, the first genu of the facial nerve, tympanic segment of this facial nerve here, and the second genu is going to be here, and then you have the mastoid segment of the facial nerve. This region here is called the facial recess. So we just elevated a tympanomeatal flap. You see, I didn't create anything yet, but just elevating a tympanomeatal flap, we can already see with an angle endoscope, of course, sinus tympani and facial recess, which are the two most important regions when we talk about residual disease. So this is very important for us, especially when we deal with cholesteatoma, that we can see without destroying a lot of bone, the two most important areas when we talk about cholesteatoma. Because Dave Pothier, which is my friend from Canada, which died unfortunately 2 years ago, he had a very good quote. He said, to remove cholesteatoma from the mastoid is not difficult. And it's not. To do a mastoidectomy is not difficult. You know the limits, it's not difficult. But to remove cholesteatoma from the middle ear, that is difficult. And with endoscope, the advantage, and that's why I always like to stress that the endoscope is made for the middle ear and the mastoid is made for the microscope. So the endoscope is very nice because it can give you, without destroying a lot of tissue, without destroying a lot of bone, transcanal can give you this that you can work, understand, and see the disease. And once you do this, you can remove the disease, improving your surgical results when we talk about surgery. So we have facial recess here, sinus tympani, posterior sinus or anterior sinus, sinus subtympanicum, promontory of the cochlea, Jacobson nerve, supratubal recess, which is the third most important area when we talk about residual cholesteatoma, and the anterior tympanic space. So you can see this just elevating a tympanomeatal flap. I didn't correct anything yet. And in real life, it's like this, especially when you have cholesteatoma, because when you have cholesteatoma, the cholesteatoma has already done part of the surgery for you because it erodes a little bit of the attic area. So you have all this region. So we have here the anterior crust, the posterior crust, cochlear form process, and then you can have this whole 360-degree anatomy of the middle ear and those recesses, which for me is the most beautiful anatomy of the whole ENT. It's more beautiful than the nose, I think, and it's very challenging anatomy because you can understand and you can see a lot of things that you have read about it on the books, but sometimes you have never seen in real life, because with a microscope it's possible to see. It's not impossible, but sometimes you have to destroy a lot of bone. You have to do a lot of bone work in order to see the same things that we see elevating a tympanomeatal flap. It looks like a joke, but it's not a joke. Now I'm going to correct a little bit, and then once we correct and we don't need to remove a lot of bone to have more anatomy, you can see better the facial nerve, the tympanic segment of the facial nerve, or the tympani is here, and you can see the whole process, the long process, is in a very good way. Of course, you have to have a very good and sharp curette also in surgery. You can use the piezo device if you want to do that. Dissection is a very good Italian device, but I like to use the curette. Or the burrs. You can use also the burrs. One tip to use a burr here is, first of all, you have to reduce the RPMs, the rotations per minute, because sometimes when we put like 80,000 or 100,000 RPMs. Here you can put like 5,000, because if you put a lot of rotation, you can have a lot of bone dust, and since you don't have the second hand to clean it, you can have a foggy image on your endoscope. And the worst thing that can happen during endoscopic surgery is not to have a good image. The advantage of endoscopic surgery is to have a good image. If you lose that advantage, you should do another kind of surgery. So we are trying to displace the chorda here. Sometimes in this section, I don't preserve the chorda. Of course, in real life, you should try to preserve the chorda as much as we can. Sometimes you can't. If you have cholesteatoma involving the chorda, sometimes you have to cut the chorda. But it's also a very nice thing to know the instruments. This is a Thomason dissection. I like it very much. For me, it's like a workhorse, and it's a very important instrument to perform cholesteatoma surgery. So once again, we can see the tympanic segment of the facial nerve, lateral canal. About the instruments, it's very important, because if you want to do endoscopic surgery, first of all, you learn some things. First of all, it's more difficult, I think, the learning curve of endoscopic surgery than compared to the microscopic surgery. Second of all, to do endoscopic surgery, you have to have a learning curve. So you have to start with small cases, ear tubes, or even at the office, looking at the ears with the endoscope, trying to remove some wax with the endoscope. And then third most important thing is you should never start, even if you are the most experienced surgeon in the world, you should never start with the cases that you already do with microscope. Because if you do this with the endoscope, sometimes you cannot perform the same surgery, and then you can be frustrated. If you have frustration, it's not good. And then one important thing is to do basic stuff, to do meringoplasty, tympanoplasty. The basic tray that you have today in your hospital is more than enough. But to do cholesteatoma surgery, and I compare cholesteatoma surgery to the frontal sinus surgery, you need to have curved instruments, curved suctions, curved instruments, curved peaks. And it is very important because sometimes I see people trying to do cholesteatoma surgery with the normal ear instruments that they have. It's like trying to perform frontal sinus surgery with the septoplasty tray. Exactly. It's going to be difficult, and then you're going to be frustrated again, and this is not good. So it's very important to have the correct instruments, very sharp instruments in hand in order to perform this kind of dissection. So facial nerve, you can see here the tympanic segment, facial recess. You can curette a little bit more to expose more the facial recess, and then see if there is cholesteatoma. But look, even when we curette, it's not a big curetting, it's not a big bone removal, because we are using the angle endoscope, and then with preserving the ossicular chain, even doing this small curettation, we can see the facial recess here, anterior crust, posterior crust, and we could see in the past also the region of the mastoid antrum, preserving the incus. But of course, most of the surgeries, especially when we talk about cholesteatoma, the incus is already eroded, and then we remove the incus. And then I am probably the number one enemy of the incus. I don't like I think the incus is too big for us. So, and the space, it's too small to have this ventilation. It's very easy to close with webs or fibrous tissue. So whenever I can, I remove the incus. I must confess. When you remove the incus, it's like doing an antrostomy, a maxillary sinus antrostomy. You have a big ventilation route between the eustachian tube, the middle ear, and the mastoid. So this is very nice to see. So once again, we can see the anatomy of the oval window. We can see this very close-up view to the oval window here. We can see the annulus of the oval window. We can see the round window also region in the annulus. We can test the reflexes. Sometimes this is very nice to, if you have a chance to participate in one course, in one dissection course, it's very nice to see the details that the endoscope can bring to you, especially in cadaver, because in cadaver you can be more aggressive to those details and to put the endoscope more inside the middle ear. You can have this close-up detail of the sinus tympani here, the ponticulus and the posterior crust of the stapes. So this is a very, very nice way to try to understand the anatomy of the middle ear. So I think the anatomy of the middle ear, of this 360-degree travel, also like this, was like this. If you want, I can progress, trying to remove the incus and go into the mastoid, but I think it's not the message here that I want to pass. The message here is the endoscope is a domain of the middle ear, and the microscope is a domain of the mastoid. Of course, you can use the endoscope in the mastoid, or you can use the microscope in the middle ear. But I think the microscope is a better instrument at the mastoid when you want to do mastoidectomy, and the endoscope is a better instrument when you want to perform surgeries in the middle ear. So stape surgery, tympanic glomus, cholesteatoma in the middle ear, everything in the middle ear, in my opinion, should be done under endoscope. Everything in the mastoid should be done under microscopic view. But it's polemic, but see, we can see the canal, and we can see already the antrum here preserving the incus. So I think it was the dissection. Do you want me to show more things, or participate in debate?
I think that, Joao, if you agree with me, we have tons of people connected on Facebook and YouTube, and due to this, I would like to do one thing. If you let me do it, I would love if we can make a part 2 of this, and by saying that, I would like to address once again the possibility to have you once again as a guest for one of our ground rounds. If you agree with this, we can plan another session, and then you could manage it and proceed to go further. So by saying that, due to the fact that we have a little bit more time, I would like to plan with you for the next few days another session to go ahead with the dissection. So in order to do this, I would stop. I'd like to ask if we can stop today. Are you agree with me? Great. So
Completely.
okay, so let's do one thing. We will not give anyone questions. We will not allow to do question today because I want everyone that participating today will be able to reach for the second segment. And after that, all the questions should be done. And in order to do this, if anyone participating today, I would stress once again that everyone should participate on part 2 for questions. Okay?
Perfect. Completely agree with you.
Okay, thank you. So we will manage it maybe tomorrow to plan a date for this. I think that the time is proper. If you agree, we will start once again at 6 p.m. because many people connected today from all around the world. So for all the attendees, we will give you some tips and information on our Facebook page, on my page, on the association page, on Joao's, Flavio Nogueira's page. So if anyone interested to get more involved in this and get more information for this anatomical dissection and middle ear anatomy by endoscopic approach, or maybe in the future also some surgery, live surgery, please stay connected and we will see you for, I think, probably next week, if you agree with me.
Perfect.
Great.
Thank you very much.
Thank you once again for all the attendees. We will get more information soon. Bye bye. Have a good dinner.
Grazie mille. Ciao.
Ciao ciao.